or they can have a large hiatal hernia, or they can have some relaxation of the lower esophageal sphincter, which is also called TLESR. So everybody has brief relaxation of the lower esophageal sphincter. That's a normal phenomenon. But when it is prolonged in duration, that's when the stomach contents reflux all the way through the mid esophagus and the upper esophagus. That's when we feel symptoms, the typical reflux symptoms. Um, so once the symptoms tend to be chronic, they tend to have complications from it. Um, the most common risk factors, obese, having a large hiatal hernia, as we mentioned. People with smoking tend to have more aggressive symptoms, even NSAID use with advanced age, and people with anxiety and even family history of having reflux symptoms, severe reflux can put them at risk of having GERD. Once somebody has reflux for more than 5 years, and especially if they have a lot of erosive esophagitis or reflux esophagitis, the risk of Barrett's esophagitis goes up. So we will be discussing about who to screen for Barrett's esophagus and what the surveillance protocol is. Um, so once somebody has GERD, we have to think if they're having just the esophageal symptoms or extra esophageal symptoms or syndromes. If they have, they're symptomatic, if they have like typical reflux symptoms, and as I mentioned, and then they can have some symptoms with esophageal injury, like if they have reflux esophagitis, if they have reflux strictures, they can have Barrett's esophagus, or even when the acid exposure is prolonged for many years and it's not controlled, they can have risk of adenocarcinoma. So these are the typical esophageal syndromes, but they can have extraesophageal syndromes also. They can have an association with the chronic cough. They can have reflux laryngitis, or even asthma-like syndrome, like reflux asthma-like syndrome. And even some people have dental erosions, the teeth fall off, especially with somebody with poorly uncontrolled reflux. And then very rarely some have, can have pharyngitis, even like sinusitis. And then when the chronic acid refluxes into the lungs, they can have some associated fibrosis also, pulmonary fibrosis also. Though there is no direct association or causation, it may be something to be keep in mind. Um, so this is the GERD syndrome classification or Montreal classification. So whenever somebody presents with some atypical symptoms in clinics, think of GERD also in the differential diagnosis. So once you establish the diagnosis, then what you do, you basically start with modification of risk factors. Meaning if somebody is very obese, try to advise them to lose weight. For any obesity related outcomes, they should have at least 10% of weight loss, be it be fatty liver or like GERD or like any other complications from obesity. And then if you think they're appropriate candidate for gastric bypass based on their BMI and then associated comorbidities or associated medical diseases, you can refer them to gastric bypass. And you should strongly encourage them to stop smoking. And then typically they should eat small meals. Maybe they can eat frequent, but it should be small meals. And then at night, they should elevate the head end of the bed so that they can have some benefit because of their positioning of the esophagus. And if these symptoms don't improve, if these measures don't improve their symptoms, then you start medical therapy. Obviously, PPI is the preferred choice. It doesn't matter which PPI you choose, and also if the symptoms don't respond to one PPI and there is no benefit of switching to other PPI. And you can, if somebody, if he has any strong reservations regarding PPI, which we will discuss, you can try on H2 blocker. So, I mean, recently there have been a lot of concerns regarding chronic PPI use, especially kidney disease, osteoporosis, and even concern for dementia, especially in elderly people. If they're used for like prolonged use, like decades. But none of them are like substantiated with a solid proof. But your goal is to use the smallest amount or smallest dose of the PPI uh, to control the reflux symptoms. From time to time, you have to re-evaluate if they need still a higher dose of PPI or still they need twice daily PPI. If they think, if the patient reports that their symptoms are better, maybe you can try to cut down the dose. But the long-term complications that have some um, evidence are like osteoporosis. So be careful if you're using PPI for a prolonged period in a postmenopausal woman or elderly male, because the risk of osteoporosis and fractures is high. And also chronic kidney disease. If somebody has chronic kidney disease, re-evaluate the necessity for PPI. You can cut down the dose or you can use H2 blocker instead. So once these, you start with once a day, increase the dose, titrate it to twice daily. Even if their symptoms are not controlled, then you have to reassess if they really have the true reflux syndrome. Sometimes what happens is they can have even non-acid reflux, like whatever contents in the stomach can reflux that can give symptoms. So you have to do maybe a 24-hour pH monitoring to establish if they have a real acid reflux. And if those measures don't improve their symptoms, then you go for surgery. Meaning, let's say if they have like a large hiatal hernia, obviously fixing their hernia will improve their symptoms. If they also look for any motility disorders or any other secondary cause that causing their reflux symptoms. Any questions so far on GERD? Okay, so next, let's look at hiatal hernia, which is the one of the most common findings on an EGD when you report the EGD. So usually the GE junction or gastroesophageal junction, as you look in the picture, stays around 40 centimeters from the incisor teeth. So the pale mucosa in the esophagus and the pink mucosa in the stomach usually meets at the gastroesophageal junction. That's usually the inlet of the diaphragm where the esophagus meets the stomach. But what happens is that part of the stomach, as you can see in the next picture, comes into the chest. That is called hiatal hernia. It could be direct extension or sliding of the stomach into the stomach, which is called sliding hiatal hernia, or type 1, or the stomach can slide into the chest beside the esophagus, which is a type 2, or it can be mixed. It can slide into the side of the esophagus or directly into the chest, which is a mixed hiatal hernia. So as you can see in this picture, the diaphragmatic indentation or where the diaphragmatic impression is shown with an arrow. And then you have the squamocolumnar junction where the pale squamous mucosa of the esophagus meets the pink columnar mucosa of the stomach, which is the squamocolumnar junction. So what you see, we have to see where this gastric fold ends, okay? And then you also look where this pink mucosa and this pale mucosa meets, which is the squamocolumnar junction. If the distance between them is more than a centimeter, that means they have salmon colored mucosa or Barrett's mucosa. That is called Barrett's esophagitis, which we will be discussing in the next slides. So these are the things you look at when you look at the EGD report, look where the GE junction is, look where the diaphragmatic impression is, and also look if where this squamocolumnar junction is. From that, you will get an idea if they have a larger hiatal hernia, if they have a Barrett's esophagitis. which which may direct your treatment for GERD. So the next picture here on the right-hand lower side of this slide, on this slide, shows the retroflexion view, where you see a large hiatal hernia. When you look at from the bottom, that's what the retroflexion view is. Um, so this slide here, the pictures here depict different stages of reflux esophagitis. Obviously, when there is chronic reflux into the esophagus, you see some mucosal injury. So the first two pictures, there is not a lot of mucosal injury here, but you still see some redness. Whereas in the top right side, you see there's a little bit of break here. And then as you progress at the bottom pictures, you see the mucosal break extends beyond 5 millimeters, but they don't meet here, which is grade B. On grade C, obviously more than 5 millimeters, and there is some communication between these two mucosal breaks or mucosal, which is ulcers. And then on grade D, you see more than 75% of the involvement of the esophagus. This is the grading or LA classification of reflux esophagitis. Obviously, when somebody has grade C and grade D reflux esophagitis, they have associated dysphagia, and they're at risk of having Barrett's esophagitis, and even they can have food bolus impactions. So you have to keep in mind. So when you see this kind of pictures on the EGD, it means that you have to be aggressive with their antacid therapy with the PPI, and even they might benefit from sucralfate to coat the mucosa. This is the same, a cartoon showing, grade A to grade D esophagitis. It's just a grading of esophagitis. And then here it depicts a chronic complication of, chronic reflux disease, where the lumen has significantly stricture, causing an esophageal stricture. And this patient had dysphagia and food bolus impaction. So what we are doing here, we are just passing a wire through it, and then we are dilating the stricture so that they can have some relief. And then here, these pictures depict a ring called Skadzis ring here. So this is nothing but a mucosal ring seen in the esophagus, which is one of the common causes of dysphagia. And then the bottom part here shows like incomplete ring, which is also called esophageal web. So these are one of the common causes of dysphagia. Any questions so far? Okay. So next one is one of the common diseases that we encounter is Barrett's esophagitis. It is significant because it can progress to adenocarcinoma. So that's the reason why we have to identify, screen them properly, and then do proper surveillance so that we can prevent adenocarcinoma. So Barrett's esophagus, as I mentioned before, the esophageal mucosa is lined by squamous epithelium. So when that squamous epithelium is replaced by columnar epithelium from the stomach, that's called Barrett's esophagitis. In addition to that, you should see definite intestinal metaplasia containing goblet cells. So this is a requirement to say Barrett's esophagitis. So the reason it happens is what happens when there is chronic exposure of the esophagus to the acid, then the esophagus has to protect itself. So the squamous mucosa becomes columnar, because the advantage is the columnar mucosa has these goblet cells which can secrete mucus so that it can offer some benefit. So that's the reason why it tends to do that. But what happens is if it progresses to intestinal metaplasia, then it becomes dysplasia, and then it becomes cancer. So that's the reason why we have to identify it and then do proper surveillance. So even though a lot of people have GERD, which is very common, only 1 to 2% of them have Barrett's esophagitis. That's the reason why we don't need to screen everybody with GERD for Barrett's esophagitis. But the factors that are associated with increased risk is when somebody has chronic reflux symptoms more than 5 years with at least two or more of the risk factors, like being a Caucasian, being a male, and above 50 years of age, and history of smoking. Even if they had a history of previous smoking, it's a risk factor. And then if they have family history of Barrett's esophagitis and then obesity. So if somebody reports, reflux symptoms more than 5 years, and then you see any two of these risk factors, you should refer them for an EGD for a Barrett's, esophagus screening. Um, and then once they have Barrett's esophagus, the risk of adenocarcinoma obviously goes up. So we have to keep that in mind. Um, so as you can see in this picture, on the top two pictures, you see the gastric folds in panel A, and in B, you saw there's some pink mucosa here. Obviously, that is the stomach. But when you look closely where this gastric fold ends and then where the pink, the pale colored esophageal mucosa starts, there is at least a 2 centimeter gap here. This is also which typically described as a salmon colored mucosa, which is consistent with Barrett's esophagus. So when you see that, you have to identify the landmarks where your squamocolumnar junction is, where the gastric fold ends, and then you have to take 4 quadrant biopsies. And every 2 centimeters, you should get at least 8 biopsies to prove that there is no Barrett's esophagitis. If you can't get 8, at least you should get in 4 quadrant biopsies. So this is the pathology slide. Obviously, if you look at the top portion of the pathology slide, you saw stratified squamous epithelium of the esophagus in multiple layers, and then you see the cells with this blue nucleus. They're pushed together, and then you saw these glands with goblet cells. Goblet cells are this whitish with a little bit of bluish hue. Those are the goblet cells. So this is the typical, Barrett's esophagitis, also mentioned as intestinal metaplasia, because it has to withstand a very high acid with very low pH. So that's the reason why it transforms like that. So this is another slide from the same patient showing a lot of goblet cells, these little white, these white cells here with a lot of bluish hue. These are the goblet cells. So if you see that in the esophagus, it's not normal. So that may indicate Barrett's esophagitis. So if you get a board question, one of those scenarios with these goblet cells, obviously there's Barrett's esophagus. So that's the purpose of it. So once you identify that, the mainstay of treatment is to do PPI to reduce the acid and also to control their reflux symptoms. And then once somebody has Barrett's esophagitis, then you have to assess the risk if they're at risk of adenocarcinoma. So what you do, you screen you take multiple biopsies every 2 centimeters to make sure there is no dysplasia. If they don't have dysplasia, then they will get a repeat EGD in 3 years. If there is low-grade dysplasia, then you have to prove it by taking biopsies every 1 centimeter. Then you should refer them for endoscopic treatment. If they have high-grade dysplasia, obviously they should get an endoscopic therapy like an ablation. So the significance of this, these are, you can get typical, board questions here. Once you screen for Barrett's esophagus, then they ask you what you do if there is no dysplasia, low-grade dysplasia, and high-grade dysplasia. So the things you have to remember, even if they have low-grade dysplasia, if they are good candidates, consider endoscopic therapy. If there is no dysplasia, then you advise them to get an EGD in 3 years and then give them a PPI to control their reflux symptoms. Sometimes there is another board question. They will ask you, what do you do if there is indefinite for dysplasia? So in that case, what you do, you give them PPI twice daily for at least 3 months, and then you repeat another endoscopy. Let's say if the repeat endoscopy shows dysplasia, then you follow the protocol. If it still shows indefinite dysplasia, then what you can do, you can repeat an EGD in 12 months. So this is a typical board question scenario. Man, then they will ask you, well, what you do? There is no dysplasia, but there is a small nodule in this salmon-colored mucosa. Then what you have to do, you have to remove the whole nodule, even if it is tiny, with EMR, so that you can get good margins, and then you have to prove that there is no adenocarcinoma inside the nodule. So let's say even the margins have some adenocarcinoma, then the treatment completely differs. Then you have to stage for adenocarcinoma of the esophagus, and then you have to go for either local or systemic therapy. So that's the significance of that. So all these 4 points are good board questions for internal medicine. So just keep them in mind. Any questions on Barrett's? Okay. So next, let's go to one other common esophageal disorder called eosinophilic esophagitis. It has significance because you might be seeing a lot of patients, especially young people, with acute food bolus infections, especially in our area, in Chattanooga area. There's a lot of people with like environmental allergies, so that puts them at risk of having eosinophilic esophagitis. So if you're on call for GI, it's very common. Within a week you will be getting at least 4 or 5 of them. So that is so common. So that's why you should know about this. So what happens is, it's a type of, the dysphagia occurs because of diffuse eosinophilic infiltration in the esophagus that causes some changes in the mucosa, making them prone for dysphagia. So usually associated with a lot of food allergies. Even if they don't have any specific food allergies, they can have like common like environmental allergies, and even people have like asthma or like any atopic like dermatitis or anything like that. So this is the common associated risk factor. Then it manifests as dysphagia, especially to solid food. It happens, acutely presenting to ER with food bolus impaction. And between children, it's very common. They have these non-specific symptoms. They have, poor feeding. They can have nausea. They follow the growth curve. That you. So if they have any asthma or any other food allergies, so we have to keep eosinophilic esophagitis in mind, especially in case of a child. So on pathology, what happens is the eosinophilic infiltration occurs. If you take biopsies, typically you have to take biopsies from the proximal portion of the esophagus and the distal, and then you see at least more than 15 eosinophils for high power field. And then you can see small eosinophilic microabscesses, and then you can see some eosinophilic granules, and then when it's chronic, it goes on chronically, you can see some fibrosis in the epithelium, subepithelial area. So these are the typical pathology findings. I mean, they may not ask you on pathology, but they can, definitely test you on, let's say, young 30-year-old male comes to the emergency room with acute, food bolus infection while he's eating meat, and then they can show you the picture, and like this, and then they can ask you, what is the treatment, So this picture here shows that there is a meat balls, meat impaction in the food in the first picture. And then his esophagus, there are some vertical lines here. You see these whitish like granules like thing, like they look like sand granules. And then there are some circumferential, there are rings. Those are the typical findings on the eosinophilic esophagitis. So you can get an EGD picture like this on boards, so which is typical, it can alert you to the possibility of eosinophilic esophagitis. So I don't think they will ask you, on a pathology slide, but just to keep in mind, the typical eosinophilic esophagitis, you can see this, a lot of, this pink, cytoplasm with eosinophilic granules. If they give you the picture of esophagus and a biopsy like this, just remember eosinophilic esophagitis. So Well, you diagnose eosinophilic esophagitis, then what you do next? So the next step is give a high dose PPI twice daily for at least 3 months. So what happens is there is an entity called um, reflux, eosinophilic esophagitis, associated with gastroesophageal reflux. So what happens is when there is chronic reflux into the esophagus, you can see significant eosinophilic infiltration in the esophagus, confusing with eosinophilic esophagitis. So to differentiate that, what you do, you give PPI in high dose for 3 months, and then you can repeat EGD in 3 months. So if it responds very well to the PPI, that may be more related to the reflux. Okay. But if it does not remember, then the things you can do either topical steroids or you can give oral or systemic steroids. You can use fluticasone and budesonide that you use for COPD and asthma, but you ask them to swallow instead of inhaling because it has to coat the esophageal mucosa, which is completely different from COPD treatment. When somebody uses it for COPD, you tell them just rinse your mouth, but actually they have to swallow here. And then, so which puts them at risk of having Candida esophagitis. And then, as they have very high incidence of food allergies, everybody with eosinophilic esophagitis should get a screening for food allergies. They should see an allergy and immunologist. And then, if they identify any specific, diet, they can eliminate it. If not, there is a common board question. They ask you, what is the 6 food elimination diet? So because these are the most common foods that cause eosinophilic esophagitis, like wheat, milk, eggs, soy, peanuts or tree nuts, fish or shellfish. So these are 6 foods that cause commonly implicated in the eosinophilic esophagitis. So they can ask you a board question on that. And then there is elemental diet that's followed in children, but it's very, very expensive. It doesn't have any taste. It's not palatable. It's not advisable for an adult or even for children because to tolerate such kind of diet, you have to do an NG tube, give the diet through that. But it's used only in like severe, severe cases where they can't tolerate any diet, which is very, very rare in adult population. Um, and then eosinophilic esophagitis can cause significant strictures when it is chronic. So what you do the medical therapy first, and then if they don't show any improvement, then what you do esophageal dilation with a balloon or a Savary dilator. Any questions on that so far? Okay. So next, another common entity you see, typically, let's say you got a guy, who had some urinary tract infection or a pneumonia. You gave them a course of steroid. Gave them a course of IV antibiotics, or you gave them a course of steroids for COPD or asthma. So a few weeks later, they come back complaining of severe dysphagia or odynophagia. Then, the common possibility is Candida infection or Candida esophagitis. So when you do an endoscopy like that, the esophagus looks like that. It can vary depending on the severity. So, if the symptoms are mild, you can treat them empirically as an outpatient. But if the symptoms are severe, they have severe odynophagia, you have to do an endoscopy because not only the Candida esophagitis, they can have even herpes or some opportunistic infections like CMV if they have any immunosuppression status, especially patients with transplant. They have been on some immunosuppression for a long time. So you have to keep other infectious cause of esophagitis in differential, like HSV and CMV. And moving on to motility disorders, as we know, there are a lot of motility disorders that can affect esophagus, which is, they can have like hypermotility, with increased contractions, like, corkscrew esophagus, or, diffuse esophageal spasm, which is the diffuse esophageal spasm, or impaired motility, especially, the degree can vary. That can be associated with any rheumatological diseases like scleroderma, or they can have a specific entity called achalasia. You might have came across these patients once in a while. So what happens is here there is no motility in the esophageal body. So there is no peristalsis. It can vary from just impaired peristalsis to complete absence of the peristalsis, depending on what kind of is achalasia you have. And then the lower esophageal sphincter does not relax. So what happens is when you eat in the food bolus, once it is pushed to the esophagus, the esophageal muscles have to push it down to the lower esophageal sphincter. So once it goes through peristalsis, the lower esophageal sphincter has to relax. Then the food bolus goes into the stomach. So what happens here, there is no motility or movement in the esophageal body. On top of that, once it touches the lower esophageal sphincter, the esophageal sphincter does not relax. So that's the reason why the food is stuck there, or even the secretions, even like liquid, whatever, stuck in the esophagus. So that's the typical achalasia. So it goes into like three types, depending on how much impaired peristalsis. Type 3 are the which is the typical achalasia. There is no peristalsis at all with um, with inability to open the lower esophageal sphincter. So obviously, dysphagia is the most common symptom that we encounter. And then, the pathological mechanism is that the myenteric plexus ganglia degenerate so that there is no inhibitory control on the lower esophageal sphincter. So what happens, those inhibitory neurons have to be inhibited. So it doesn't happen. So that's the reason why they get this lower esophageal sphincter spasm. So then when you do like a barium swallow or upper GI, then you see the esophagus like that. So you might have read in USMLE or even textbooks as a typical bird's beak esophagus, where you see this distended esophagus with a narrowing at the end. This happened because of the spasm here, but as there is no peristalsis, food keeps accumulating, food and secretions keep accumulating here, and then the esophageal body dilates. Sometimes the esophagus looks as big as a sigmoid colon. So um, then if you do an endoscopy in such people, so obviously on this panel, you saw here the lower esophageal sphincter, there is a stricture or there's a spasm here because it does not open. And if you look at the esophageal body, it's very dilated and there is some pulling of the secretions in the esophagus. So this is the typical achalasia. Sometimes you can see a lot of food stuck in here, a lot of liquid and secretions impacted here. So if you identify an esophagus like that, to confirm the diagnosis, you do manometry study. So on the manometry, you see that there is no peristalsis or ineffective peristalsis, and then you measure the pressures in the esophagus. Obviously, the lower esophageal sphincter does not relax below 15 millimeters of mercury. So that's how you diagnose achalasia. So once the diagnosis is done, then you have to the treatment options vary depending on the severity. If the symptoms are mild, you can just use a balloon to rupture the lower esophageal sphincter and then dilate it. If it doesn't work, they can go for surgery. What they do, they release the pressure in the lower esophageal sphincter by myotomy. We used to do by surgery in the past. Now we have some endoscopic techniques. We can do POEM, and we can do myotomy endoscopically. And then if they're not candidate for a surgery, if they have still a lot of symptoms, then you can do some local, like Botox injections to relax the sphincter. So, which is more of kind of a palliative kind of treatment. So, um, so when somebody has achalasia chronically, and then they don't get adequate treatment, then what happens is that chronic exposure to the secretions and all acid there they can have, there's also the stasis of all the contents. There's a risk of adenocarcinoma. So you have to keep that in mind. So, I mean, with that, I will end the talk. As I said, if I go to other esophageal diseases, that will be a prolonged talk, and I think we can do it some other time. Do you have any questions so far? Okay. Okay, then. So nice seeing you guys, and then we'll meet next time, okay?
Thank you so much, Dr. Parsa.
Okay, then. Bye. Take care.
Thank you.
Thank you.